The Richard King Medal Foundation has also supported a broad study that centers on infant mortality here in the region, Allegheny County, but also, of course, relevant across the country. And before I show you a brief movie that captures the key participants at our key projects, I just want to show in one slide the key types of activities that we have that generated this project. And as you can see here, on the top, we see the time spent from early pregnancy all the way to 1 year and beyond of infancy, which is the target for this investigation. And below the black line at the top, you see a depiction of several groups, 7 altogether, that pursue different aspects of contributors to maternal morbidity and mortality and how we tackle them using diverse biological approach, diverse clinical approach, apps, iPhone, smartphone apps, and other tools to be able to investigate the antecedents of fetal morbidity and mortality, all the way to fetal outcomes, infancy, and most importantly, ways to prevent it. And you see here, starting from early pregnancy, going all the way to doula interventions you'll see about in a minute, preterm connect studies that go well beyond pregnancy and beyond infancy, intervention in the NICU, and a conglomeration of all the data with an impressive project called Impressive of data integration that leads to the last project, which is about health economics and how to implement and deploy those studies in real populations. So let's see the movie, please.
Hi, my name is Tamar Krishnamurti, and I'm an assistant professor of medicine and a co-founder of Naima Health. Naima Health's flagship product is the My Healthy Pregnancy mobile health platform, which offers early risk identification and intervention during pregnancy through information collected and shared through the My Healthy Pregnancy app. The My Healthy Pregnancy mobile health platform was built by our team of social scientists, physicians, and pregnant people. On the left is the smartphone app that's prescribed to pregnant patients at their first prenatal visit. This app collects self-reported data from the patient each day and integrates machine learning with behavioral science to model each individual patient's pregnancy risk, as well as to communicate about risk factors in actionable terms to the pregnant person. On the right is an Epic integrated physician portal, which shows healthcare providers summaries of relevant risk information collected from patients with the app in between routine prenatal care visits. In the past 18 months, we've prescribed My Healthy Pregnancy to over 5,600 pregnant patients in the UPMC healthcare system, and we've had some promising initial results. For example, app users have reported and been connected to resources for intimate partner violence through My Healthy Pregnancy, which has been particularly important during times of social isolation in the COVID-19 pandemic. We also have new work identifying a major gap in communication about patient eligibility for prophylactic aspirin to prevent preeclampsia, which My Healthy Pregnancy is now working on filling. And lastly, we found that there's an increased identification of depression risk among those patients using My Healthy Pregnancy, highlighting an opportunity for early depression risk intervention. We believe that tools like My Healthy Pregnancy will be able to help us offer more personalized, more effective, and most importantly, more equitable care to patients. When our mothers are prioritized and well cared for, the overall health of our society improves.
My name is Yoel Sadowski, and I'm the Executive Director of Magee-Womens Research Institute. I'm also a professor of obstetrics, gynecology, and reproductive sciences here at the University of Pittsburgh. The broad goal of our component within this project is to understand a healthy pregnancy and to understand what can go wrong. The upper line represents a course of a normal pregnancy from the very beginning all the way to the mature 9 months when the fetus is ready to come out. Several things can go wrong that lead to diseases, such as fetal growth restriction, preeclampsia, and preterm delivery is shown on the right. When the pregnant mother develops those conditions, the goal of the provider or the physician is to diagnose them and provide therapy to either mitigate the adverse effects or lead to premature delivery, unfortunately, to prevent further complications. We know that the antecedents of those conditions or diseases occur well prior to the clinical manifestation of the disease. For example, placental dysfunction, which is a common contributor to these conditions, occurs much earlier in pregnancy. And if we can identify placental dysfunction and mitigate its adverse effect on the course of pregnancy, we can try to restore the normal course that you see in the upper line and thereby have a healthier pregnancy all the way to 9 months. We do it by 4 components. The first one is subjective data from the patient, integrating how she feels, level of stress, nutrition, and other components. The second one is electronic health records from the hospital. The third one is omics, integration of biological material that we obtain throughout pregnancy and at delivery that really explain to us the underpinnings of the biology of health during pregnancy. And the fourth one is the environment, water and air that the pregnant woman is exposed to. By integrating those 4 pieces of data into a full picture of the health and wellness of pregnancy, we can not only try to understand diseases, but also try to restore the health of pregnancy to lead to a healthier outcome at 9 months and hopefully an opening to a healthier lifelong health and wellness throughout the 90 years. Data generated from our project will help other scientists, members of our group, to provide information to pregnant women and also to families after delivery in order to improve outcome, decrease morbidity and mortality.
Hello, my name is Dania Tyler. I'm the Director of Strategic Initiatives for Healthy Start Pittsburgh. Healthy Start is a maternal and child health public health organization focused on reducing infant mortality and poor birth outcomes in Allegheny County. We know that doula support leads to a reduction in poor birth outcomes, such as low birth weight, and an improvement in birth outcomes, such as breastfeeding initiation. For that reason, we launched our Healthy Start Doula program. The Healthy Start Doula program uses the community-based doula model. The community-based doula model is a merger of the birth doula model and a community health worker model, where we use trained non-medical support people who are trusted members of the community to bridge the gap between participants and their health needs. But the success of the Healthy Start Doula program is really centered in our multidisciplinary service array, where participants have access to services throughout the perinatal spectrum. Within the first year of the Healthy Start Doula program, we received 102 referrals, attended 42 births, and supported a total of 79 families with prenatal and postpartum support. If we can make sure that a doula is available for every family who wants one at their birth, then we can reduce infant mortality and poor birth outcomes for everyone in Allegheny County.
Hi, my name is Shilpa Jani. I'm a project manager at the Center for Policy Outcomes and Prevention at Stanford School of Medicine, Department of Pediatrics.
Hi, I'm Dr. Jason Wang. I'm the Director for Center for Policy Outcomes and Prevention at Stanford University, and also the PI for Preterm Connect. In this project, we aim to leverage mobile technology to mitigate social disadvantage in the NICU and beyond by working with the UPMC colleagues.
Of course, our ultimate goal is to reduce infant mortality by way of reducing preterm births. But there are 4 intermediate outcomes that we're also interested in seeing improvements in. These intermediate outcomes are closely associated with infant mortality and preterm delivery. This logic model shows a list of Preterm Connect features on the left and how they will affect primary drivers and behavior that will then influence the intermediate outcomes. In order to assess the effectiveness of our mobile approach, we are currently enrolling participants through the NICUs at Magee-Womens Hospital and Children's Hospital of Pittsburgh. Through this randomized control trial, participants will be assigned to either the control group, where they will be given a standard discharge summary along with a paper-based supplemental health information packet, or to the intervention group, who will receive these same standard materials, but will also be oriented to the Preterm Connect app. We hope to follow these participants up to 1 year.
Hi, my name is Rich Tree. I'm an endowed chair and associate professor at the University of Pennsylvania and the Children's Hospital of Philadelphia. My team is involved in the project because we aim to predict the infant mortality through a clinical AI system that can better identify patients who are at risk of mortality. Our system is aimed to build a clinical AI system overly impressive that can facilitate clinicians and researchers to reduce the infant mortality. Our systems collects patient data and de-identify them to protect patient privacy. Our AI engine also provides mortality risk prediction and intervention recommendation to clinicians. In the previous study, we measure our model performance at different stages. The model reached better accuracy when more data became available. More specifically, during the infancy stage, our model reached highest accuracy, and the positive value was 60 times higher than the mortality prevalence. To deploy the impressive system in a clinical setting, we follow the industry standard to provide a scalable solution. To facilitate clinicians' need and workflow, our impressive system will provide a graphical interpretation of mortality risk level. Moreover, our system explains mortality risk based on ranked patient-specific risk factors from various types of clinical data. Our impressive approach and framework can be further applied to prediction of other high-risk factors to infant mortality, such as preeclampsia, preterm delivery, pulmonary hyperplasia, etc., to better protect mom and baby's health.
Hi, I'm Evan Pete, PhD economist affiliated with the RAND Corporation and the Pardee RAND Graduate School and professor there. And I am RAND's principal investigator on this project. RAND brings unique expertise at going from understanding who's at risk to addressing which interventions will reduce that risk, which will be used, and putting those all together to provide an integrated precision care and support to get people, whether it's health services they need or social services, to get people to the services that they need to reduce their risk. We have a unique data set, this impressive data set. The problem is it's observational data. So we're not able to randomly assign people to different interventions to see what's impactful, what's helpful, what's not. So we have to take this observational data and incorporate unique novel methods to isolate the effects of the interventions from all the other things that might lead to maternal and infant health, and ultimately, in some cases, infant mortality. And so we combine these predictive models of risk with predictive models of intervention utilization, and then use some novel econometric methods called double machine learning to isolate the effects of interventions by essentially comparing mothers and infants who are similar in both their predicted risk and their predicted likelihood to participate in the intervention. And as a result, we get these estimates that vary across risk level as well as across timing and other maternal characteristics to really hone in on what's the best recommendation to make for this specific woman at this specific time. Right now, we're moving from the research stage to the implementation stage, providing our models and results and recommendations to healthcare and social service providers, as well as mobile applications to patients. And the goal and expectation is that if this implementation stage is successful, we can reduce infant mortality in the county by 10 to 20%, and most particularly reduce it among those most affected, the racial and ethnic groups and low SES groups who suffer the most from this maternal and child health problem.
Once we're successful, our overall project will enrich knowledge that defines health and wellness not only during pregnancy, but across the lifespan and across all communities all over the world.
So you just saw a movie that Yoel set up that really is taking on a very serious, very challenging epidemic in our country. As Miriam talked about it, the maternal and child mortality issue is something that's not only not going away, it's actually getting worse. And so when we came to the table a few years back, we said, you know, these are complex issues. These are multifactorial issues. So not only do we need a multi-omics approach, we need a multi-resourced approach. And so we put together a team of clinicians, scientists, community interventionalists, and we educated the patient population about why and how these things could be coordinated to provide ultimately better care and, more importantly, better outcomes. So, well, Miriam said it very eloquently that Dr. Bianchi said no one patient can care for a complicated fetus. No one organization can really wrap services around a mother and child that's necessary to provide optimal outcomes. So if we as an organization can't reach out to the community and work together with them, we're never going to be able to solve these problems. Yesterday's advocacy session was an incredible day of learning for all of us. We took both payers and providers and we put them in front of community groups who are facing these very problems. And we said to the community, where are we failing you? Where are our gaps? How can we do better? And we got some really blunt feedback. We got a really good understanding of where those gaps are today and how we then leapfrog those to provide solutions for those communities tomorrow that will move these needles. This is an exciting project. We've been working on it for about 6 years. And at the completion of the project, not only will we have moved the needle for women and children in Allegheny County, we'll have built models that can be deployed in Baltimore, Detroit, New York, LA, and other counties and other cities that have similar demographics and similar issues to us. Knowing that healthcare is delivered locally, we have to understand that it's up to us to be creative with our bundled services packages. Our bundled services are designed to provide consistency, but consistency only goes so far. We have to personalize that consistency to the needs of the community that we're serving. And that's where the ears come in. That's where we need to listen. That's where we need to have relationships that go deeper so that we can continue to do that. So today, I'm gonna set you on a break now. We're gonna come back in about a half hour. But when we're on that break, I want you to think of the people in the room and maybe the people in your community that could partake in issues like this. If you don't have a computational biology center at your location, get involved with somebody like Rand who can do those complex algorithms and create infrastructure for you as an organization.